Okay. So let's continue. So I was just saying I was taking us through clerking in 7C or history taking in the cardiology ward. And it's very important to, just as Angel said, you start with establishing rapport with the patient. You shake the patient's hand. I'm going to emphasize on shaking the patient's hand because from next week, we'll be having a more systematic approach with focus on diseases. Now history taking is ending this week. So by tomorrow, please try and clerk a couple of patients and get your history right. And then now, as we continue, we'll be talking about history in specific disease and slowly introducing the systemic exam. So you shake the patient's hand. I'm going to really emphasize on this. You shake the patient's hand, you introduce yourself and state your name and designation. Designation, you have to be smart about it, yeah? Because you can't go around willy-nilly saying that I'm a student, as much as I'm not saying you omit or you try and impersonate a physician. I've not said that. I've not said you say you're a doctor. The patient can call you a doctor. That's okay. You can either confirm or deny that you're a doctor. That's up to you. The crime is impersonating a doctor, but if they call you daktari, just have a way where you can take the history. You know, patients are really apprehensive about students because we come, we ask questions, and then we don't help them. So try and be of help as well. If they ask you to pass them their glass of water, please do. If they say they're uncomfortable in 7C, you'll find these guys, most of them have pulmonary edema. I know you guys haven't yet really stepped into IMED properly, but patients with pulmonary edema are more comfortable at a 45-degree angle, yeah? So you can't be having these patients lying down. So maybe they'll ask you, help me sit up, Daktari, and please help them. So be helpful. And then obviously you ask the patient for consent, yeah? You ask the patient for consent. So yeah, number one, it's okay. So Mark, that's an important question. That's a good question, and I like the way you've asked it earlier on, and I'll address it since I'm talking about introduction. Number one, Mark, we confuse OSCEs. OSCEs are objective structured clinical examination questions. They are a whole different set of exams that are done in sixth year. What we do are OSLAs. OSLAs is a long case. Yeah, OSLA or long case. So OSLA, in an OSLA situation where you have the lecturer, just introduce yourself with your proper designation because they have been prepared in advance. So you'll tell them, hi, my name is Shono Mundi, a fourth-year medical student, and I'll be here examining you, and then you get consent, you explain the exam, you get consent. I'll explain all this as we step into the systemic exam. I'll tell you how you should introduce yourself. But when you are in an OSLA case or a long case, you introduce yourself as a student with your proper designation, give them your name, you ask for consent, then you proceed. But we'll take you through. But that's a good question, Mark. So then you ask for the patient for consent, because sometimes you can easily go there and just say, okay, unaitwa nani, or what's your name, what's your age, when were you admitted, and then the patient maybe has no idea what's going on. And then now when you want to get a HPI, they think maybe you're just brushing through. Then when you want to get a proper history, they withdraw consent in the middle, and now you've wasted paper and you're killing our environment, yeah? So you ask the patient for consent. Is it okay if we talk? Uko sawa tukiongea? Yeah? Maybe there are some people who don't speak English, but forgive me, since they speak Kiswahili more, but don't also assume you don't want to patronize them. So you just ask and say, uko sawa tukiongea, are you okay if we talk for a bit? And then you start talking to them. Then always let the patient talk about their story for 10 minutes without interruption. So during this 10 minutes, you're using the time to see and kind of visualize what could be the problem. And then now you start coming up with a way to approach the patient, yeah? And that's the way to go about it. So you let the patient talk for 10 minutes without being interrupted. You make sense of all that they've said. You're coming up with a pathology in your head, yeah? So in the severe word, common pathology is acute decompensated heart failure. My friend Adnan will take you through it next week, God willing. By next week, a couple of groups should have met Adnan for heart failure. So now you make sense of all they've said. Then now we go to, just give me a moment, slide will move. So now we go to the biodata and the cardiology ward. So now you give name. Obviously, you have to have the name. You need to have the age. You need to have the gender because male patients have a greater risk of cardiological disease or cardiovascular disease than females. But females are interesting because they have atypical presentations. Yeah, I hope you guys are getting this. Females have a typical presentation in the cardiology ward. So don't be shocked when you're clerking maybe a 60, 65-year-old woman and she tells you, I had a really bad stomach pain that was epigastric in location. It's a common presentation for ischemic heart disease in elderly women. Yeah. And then you ask about the residents. The residents in 7C doesn't have a lot of importance, but it bears importance because uh, of the proxy nature between resp and cardiology. So in pulmonology, the residence is important because there are certain conditions in certain residents. In CVS, it's important because those respiratory conditions can cause heart failure because they'll cause copulmonale that can cause right heart failure that can later cause biventricular heart failure. Yeah. And then you ask about occupation, although it's not of significance, but it can help you really tell where this guy is in terms of socioeconomic status, which is very important in cardiology. And then you ask about the duration of admission, and then you talk about the chronic conditions I was mentioning. So are they hypertensive? That's a common chronic condition you'll find. There are some who have compensated heart failure, very common thing. So they already know they're in heart failure and they've been given heart failure medication. And you need to know, are they adherent to their medication? Yeah. Some maybe are people with a history of renal disease, end-stage renal disease. So they are on dialysis. Yeah. And you need to find out which medications are they taking, when were they diagnosed, and then are they adherent or non-adherent? Don't use compliance. Why have I said no to compliance? Compliance is a lab value, and I cannot belabor on this. Compliance is a lab value. So compliance of diabetes, how do you check compliance of diabetes? Maybe I can ask somebody present. Bet Thomas Kiprotich, how do you check for compliance in a diabetic patient? How do you say that they're compliant to the antidiabetics?
Then you look for the HB1C.
Yes, yes, yes. You do HbA1c. So how do you think we check for compliance in somebody with hypertension? What do we do? Uh, Maybe I can ask Mark. What do you think we do to check for compliance?
by
Yes, Mark?
by measuring the BPs.
Yes, yes. Ambulatory blood pressure. That is how we check for compliance for antihypertensives. So when you use compliance, you are really implying on a lab value. So if you say it's compliant, how did you know? So you say adherent or non-adherent. Yeah. And then after that, you move on. Another chronic condition of great importance in the cardiology ward is HIV. You remember yesterday we talked about HIV cutting across all systems, and it's really important to know what HIV does, where it does it, and HIV in the heart. We talked about stage 4 HIV, WHO stage 4 HIV, and we talked about it causing something called HIV-associated cardiomyopathy. Yeah. So now let's talk about presenting complaints. So as I said, you remember the model that we gave. Maybe before we continue, I can just stop share and just run us through this model now, and I'll run us through this model again later. So these are the 6 important things that must come out in your history of presenting illness. You must have a systematic analysis of symptoms, number 1. So you either Socrates pain or you operate every other symptom. Then you associate it with relevant symptoms. Notice the word relevant. Relevant is the operative word in this statement, that there are sometimes a patient could tell you that nilikuwa nimechoka alafu naumwa na mguu, and they were carrying at the same time. But ask yourself, is the kuchoka relevant to the kuumwa na mguu according to what you've read in in Hutchison's, yeah, because the presenting complaints are really analyzed in Hutchison's. And if you look at it, you'll realize that when you look at that presenting complaint in the first page of like a chapter in Hutchison, like maybe if you have Hutchison next to you, we can take a little trip there. We can take a little trip and just go to the cardiovascular portion so that I don't lose people. So like if you look at Hutchison, I'm right now on my Hutchison on my end, on another device, don't worry. So when you're looking at chest pain, you see it really describes what chest pain should be and the various causes of chest pain, yeah? So now it talks about all the possible differentials of chest pain in the cardiology setting and also the general differentials of chest pain. So you need to know that the relevant associated symptoms of chest pain, it's either somebody has a recent history of trauma to the chest, either somebody has a cough, somebody has fever, somebody has increased awareness of heart rate, somebody has palpitations. Those are the relevant associated symptoms. And then you talk about your important negatives and your important positives, which are like a mini systemic review. And what they do is that this mini systemic review kind of rules out other possible causes of the above presentation. But you'll get more and more like you'll become an expert in it. The trick that Dr. Sheikh gave us for just generally CVS, for RESP, for neuro, is that GI, is that if anything is happening in the chest, check for it in the abdomen and the head. If anything is happening in the abdomen, check for it in the chest and in the head. And if anything is happening in the head, check for it in the chest and the abdomen. And it's as true as that. You'll realize with time that they become as true as that, and you'll become better as you continue. Then you identify risk factors or etiological factors. So what really comprises of a good risk factor profile? So a risk factor profile talks about behavior, yeah? So a risk factor profile talks about behavior, and you highlight behavior and you look at behavior in terms of how is this patient living? How is the patient's diet? Is there family history? Yeah. Is there anything in the occupation that could cause this? Yeah. And then, as I said, like your history will reflect the relevant parts of your clocking. Your HPI will really talk about the relevant parts in your clocking. There's no way this patient is a smoker. And could somebody tell me what smoking puts you at risk of in terms of a cardiovascular disease? You guys are fresh from pathology, so I believe this should be easy. What does smoking put you at risk of? Maybe I could call somebody. Yes, Thomas, you can tell us.
Pulmonary hypertension, which can lead to right heart failure.
Yes, well, that's one. Any other one? Bet has said something on pulmonary hypertension, which is true. Now there's another one. Can somebody attempt? Maybe Sadia can tell us. What else can a cigarette do to the heart in particular?
Can I attempt?
Yes, you can. Yes, you can.
If I remember correctly, smoking can lead to, it can disrupt the atheromas in atherosclerosis, leading to myocardial infarcts.
That's good. That's lovely. That's lovely, Angel. That's beautiful. That's well put. Yeah. Smoking, how exactly it happens that cigarette smoke is a pro-inflammatory chemical. Yeah. And you know that the plaque is normally covered by a fibrous plaque. Yeah. So what it can do is that now the smoking will irritate, leading to inflammation, an inflammatory response that will disrupt the fibrous plaque, resulting in now this plaque being free to move, and you can get coronary artery disease and eventually an acute coronary syndrome, or what we call a myocardial infarction. So alcohol. Alcohol is a myotoxin. It disrupts the electron transport chain. It is toxic to the myocyte in arrangements, the myosin. So it causes dilated cardiomyopathy. HIV is also important. So the RVD status is important because RVD itself, as I said, it attacks cells with the CD4 receptors. And the CD4 receptors are everywhere. I told you about these cells in the heart. They're called antiscal, yeah? Or antistio, whatever you are taught. That's how they were called. So these cells express the CD4 cells. So HIV could be triggering production of viral copies, resulting in reduced nutrients for the inherent, for the myocytes. And what happens? The cardiac myocytes, what happens? They die, they become dilated. That's the theorized mechanism of action. So now, then you talk about contact with the healthcare system. So this guy probably went to another facility, had 1, 2, 3 things done, then they were referred here, or they could have come here direct and were seen at the emergency, had this and this done, so you highlight that. And then you talk about current status of functional deterioration. So let's go back to the other presentation so that we can start. Okay, so let's talk about chest pain. So now that's a common presenting complaint. And you guys will learn with time. I know you're feeling like what I'm saying is overwhelming. Maybe we can follow through. Now, so I'll engage you guys. Angel, what do you think can cause chest pain? Just whatever, all the random causes of chest pain, you know.
I would say myocardial infarctions cause chest pain. Then epigastric pain that has, I guess, radiated to the chest can also cause chest pain, like from the stomach.
What do we call that? Reflux. That's the word.
Reflux.
Yeah.
Yes. That's all I can think of. Maybe someone else can.
Who else? Yeah.
Okay.
You can if you have any more.
No, because the slide shows them. So
No, I want you guys to ignore this one, the ones that make sense to you. These ones make sense to me, but they'll make sense to you by the end of the presentation. Anyone else who has something that they're thinking of?
Maybe myocardial infarction and
Trauma.
Yes, trauma. Mark, what were you saying?
Myocardial infarction and myocardial ischemia.
Okay, yeah. So ischemia. That's nice. That's nice. That's good. And we've had trauma.
Yes. Trauma and aortic dissection.
Very nice. Those are very common things. And those are the ones we should really know. Because I remember there used to be this question on the pathology MCQs. You have a 40-something-year-old man who has chest pain tearing to the back, and you just knew automatically it's an aortic dissection. Now let me take you guys through it slowly and try and reason with me. So now, what are the structures in the chest or that have close proximity to the chest? So in the chest, you have, I don't know if we should visualize it. Let me see if we can visualize it. Just give me a moment. I don't want to, I realized sometimes I can talk and maybe niko peke yangu. So let me try as much as possible to make this as engaging as we can. So we're going to go a bit into anatomy. I want us to go a bit into the anatomy so that we can have kind of something that helps us. But okay, maybe we can talk about it. I don't have to even go there. So when you are talking about the chest, so on the chest, you obviously have the muscles that overlie the chest. So you have your pecs, You have all those muscles and you know them, you should know them by name. And then you have your ribs, yeah? Your ribs, within your ribs, you have your intercostal muscles, and you have your ribs that attach the sternum. You have the ones that are free floating or false ribs, the true ribs. And then you also have the vessels that lie underneath and lie in the groove within the ribs. And then after that, you also have now the viscera. So you have things like the pleura covering, yeah? And then after the pleura, you obviously have your lungs, you have your trachea, you have your bronchi, your primary bronchi, secondary going on. You have your heart, you have your lungs. And then after that, you know that the heart is, the thoracic cavity is divided into chambers. And we talk about the anterior mediastinum. We talk about the middle mediastinum. The middle mediastinum is where our heart is located. Majority of the heart is located. Then you have the posterior mediastinum, which talks about the esophagus being one of the principal structures that are in the posterior mediastinum. So now, if you look at chest pain from that dynamic, you realize that there could be GI causes of chest pain, like reflux, yeah? Like reflux, because if you look at how the esophagus is at the back, so acid could radiate up and be irritating. You could also have hyperacidity within the stomach itself, things like GERD. And then in GERD, you know how the stomach is shaped, and the cardiac portion of the stomach is really closely opposed to the diaphragm. That's why people get hiccups when they have hyperacidity, and that's why you get some very funny pain that you feel it even in your chest because of the phrenic nerve and its distribution. And then you could have cardiac causes of chest pain, as you've said, ischemia, your infarctions, your aortic dissections, yeah? And then you could have lungs or resp causes like pleuritis, things that cause inflammation of the pleura like pneumonia, TB, and their friends. You could also have infection, things that target the bones within the chest. So you have costochondritis, yeah? Costochondritis is something you'll read about in rheumatology. You have costochondritis. And then you have the muscles that are generally affected by trauma, yeah? So those are the basic causes of chest pain. And that's the model I want you to approach chest pain with. You can also look at chest pain in terms of this model here. I call it vindicate. So V for vascular, E for infectious, N for neoplasia, D for drugs, I for iatrogenic, C for congenital, D for drugs or degenerative. So costochondritis is degenerative. And then you have autoimmune, you have toxins, you have your environmental or trauma. So now, or endocrine. So now you have, these are the causes. You could have a pulmonary embolism. And can somebody tell me a bit about the kind of chest pain they expect to see in pulmonary embolism? Maybe I could pick someone, or you guys don't feel ready. If I just call out to you and you feel unsure, just stay muted. We'll work through it together. So let me look for someone. Sadia, are you in a position to unmute? We talk about pulmonary embolism, just a bit. If you feel unsure, by the way, guys, don't be scared. This is an open forum. As I've said, the only difference between you and I is I've gone through this experience and I came out on the other side. But you guys are very intelligent, very smart. As we progress, you'll definitely get better. So if you feel like you can talk about the chest pain, just tell me. Just feel free to unmute what you can tell me about the chest pain in pulmonary embolism. Angel, are you willing to try this one?
I'm not sure about this one. So
Okay, it's okay. Then you can, then let's just talk about it. So pulmonary embolism, pulmonary being the operative word. So the kind of chest pain it causes is pleuritic, yeah? So it'll be located either on one side of the chest, like so you could hear right-sided or left-sided, because that area of the pleura becomes inflamed and it causes pain. And then when you have a pulmonary embolism, so number one, how does a pulmonary embolism cause inflammation of the pleura? That could be a question. That's a good question because we know visceral organs, they don't have pain nerves, yeah? So now, how it happens is that you have the embolus occluding the supply, the vascular bed of the lung. And then what happens is that as the surrounding tissue starts to die, there's a swelling that occurs, an edema that occurs, yeah? And that edema irritates the pleura, because the pleura is something that the lungs are kept open by negative pressure of the pleural membrane. So that you have to know that. And once that happens, they get irritated, they feel the pain. And it's a pleuritic pain, it's worse on inspiration, it's exacerbated by a cough, and it's normally associated by a cough that is productive, and the product produces normally blood. Yeah. And it's could be, you have things like difficulty in breathing presenting as well. The chest pain in angina, we should know, it's a crushing pain. Because in angina, we know there are like 3 types. There's Prince-Mental, there's stable, there's unstable, that you guys will talk about next week. And they all have a different presentation. And then, so in your head, when you have a patient, you approach the patient has this issue, they have chest pain. This is how you attack the chest pain, and you're able to come out with differentials. I know when you guys were joining fourth year and you heard about differentials, it might have felt hard. So Mark has asked a good question. Which chest pain occurs on exertion? That's normally angina. Yeah. And it's normally stable angina. When it becomes unstable, it's also present at rest as well. But angina is the one that occurs with exertion. Why? Because it's about myocardial oxygen supply versus demand. Yeah. So when you exert yourself, there's increased demand while the muscles are not being supplied themselves. So you get that pain. Yeah. So basically those are the kind of models that I want us to go through. So let's continue. As we continue, it's going to make sense. So now we have chest pain continued. Normally, not normally, I said that when we approach pain, Socrates pain. Yeah, pain is the only thing you Socrates, by the way. You operate everything else, pain you Socrates to get the detail. Yeah. So now site, in a cardiac chest pain is normally retrosternal. So how will the patient tell you retrosternal or central? Patient will tell you, I felt the pain katikati, in the middle of my chest, moving towards my back, the inside, just uko ndani. That's called retrosternal. And then they normally tell you it occurred suddenly. But then you have a patient who has angina, as I mentioned, they could say it developed insidiously. And then now, it is normally described as crashing. Cardiac pain, chest pain is normally crashing. Anything else that's not crashing is not cardiac chest pain per se. You could have sharp pain in cardiac disease, but that's normally a sign of pericarditis, yeah? So inflammation of the pericardium. And then radiation, it's normally towards the jaw, the left jaw, and the arm. Why? Because if you look at the heart, so the most bulky portion of the heart is the left side. And if you look at the root of the phrenic nerve, I know I might be speaking Greek, my anatomy sucked, but it's important to understand clinical anatomy. So the clinical anatomy that causes this jaw pain is because the left side of the heart that's really bulky, is closely opposed to the phrenic nerve. Yeah. A phrenic nerve is normally, Stokas, where it's from, you should know it's from the cervical chain. So you should know about that. So now that's why it moves up. And the radiation to the arm is because the cervical chain and its opposition to the being a root of the nerves for the arm. So you should have a general idea of clinical anatomy. And then you have associations. I don't like putting associations in the middle. And why do you think I don't put associations in the middle? Maybe somebody can try and answer that. Why do you think I'm saying you don't put associations in the middle? In case there's no response, I can just answer this quickly. Because just imagine imagine you're talking to someone. I know some of you guys are in psychiatry or have had exposure to psychiatry lectures, and you've talked about something like tangentiality or circumstantiality as how you assess for speech. Yeah. So imagine I'm talking to you, I'm trying to communicate clearly with providing the information concisely. And then I talk about something, because if I find a positive association, I have to talk about it. And then I come back to the previous topic. Yeah. So now the moving back and forth is not attractive. It has to flow in continuous prose. So when you're talking in continuous prose, you describe something in continuous prose and you associate it with other things at the end so that you can also describe them. This is language. If you remember your noses com from English back in the day, that's basically history. Once you clocked that, you clock how to take a good history. And that's how you do it. Yeah. You ensure that their sessions are at the end so that when you find anything positive there, you talk about it. Yeah. So the time for cardiac chest pain is normally constant, or it can be intermittent, or it can be constant, but it is worse at a certain time. So don't ignore the patient who tells you, my chest pain is worse after eating, because there's a pathology for that. Don't ignore the patient who says that it's exacerbated by food. Yeah. Don't ignore the patient who talks about the chest pain being worse on exertion and being relieved at rest. Yeah. We should know those things. And then the severity is normally 6 to 8. That's serious cardiac chest pain. A patient, especially male patients, have this habit of telling you it was a 10, but a 10 is labor. And if you've seen a woman in labor, can they talk? No. Are they conscious majority of the time? They are delirious. So if they are not delirious, that is not a 10. So they could just tell you, Doctor, it was a 10. Huh? That's lovely to hear. It's between 6 to 8 for me. Yeah. And then for associations, as I've said, in chest pain, this is just asking ourselves, what could it not be and what could it be? And we are trying to really stick to the chest pain as our focus. So you normally ask about any recent history of trauma. You ask about any cough because you're trying to see, could it be a respiratory problem? Could it be a P? Could it be pneumonia? Could it be TB? You ask about any fever because it could be infectious. You ask about increased awareness of the heart rate or palpitations. And then when they tell you, maybe they'll tell you increased, I have been feeling those palpitations, nasikia kama moyo inapiga piga. You try and ask them to tap it out. Yeah? So that you can easily know, is it an atrial fibrillation? Yeah? Is it a tachyarrhythmia? Maybe due to re-entry. So if you find a patient tapping it quickly and it's regular, that's probably a tachyarrhythmia. You know, when somebody gets a myocardial infarction, another risk is an arrhythmia. And then it is atrial fibrillation or AFib when the patient taps it and it's irregular. So they'll tell you and then they have a beat drop. The heart starts beating quickly, then stops, then beats quickly, then starts beating quickly but strongly. That's AFib. And then you should know that one is a very serious condition. It's an emergency. Then you ask about sweating. So this sweating versus night sweat is very different. I told the guys in group A to read about the mechanism of night sweats in lymphoma and in TB, and I hope they read. You guys, I'm going to tell you the same. There's a reason the sweating in TB and in lymphomas occurs at night. It's not throughout the day, it's at night. When you ask a patient, ulikuwa unatoa jasho ama were you sweating a lot? Be sure to ask them about the time. If they are sweating throughout the day, that's an autonomic dysfunction. That's diaphoresis. Could be due to these cardiac things that you're talking about, could be due to endocrine things like pheochromocytoma. Yeah. But if the patient tells you specifically, I was sweating at night, that has a purpose. And I'm going to tell you guys, read, and I've given you guys a clue. Number one, you know the chemical that is released because that chemical, you talked about it when you're differentiating AML and ALL in hematology. Then number two, the second key I'm giving you guys is that the reason it happens at night is due to lymphocytes. And now you go and read. So you ask about difficulty or change in swallowing, because once again, it could be our friend in the posterior mediastinum called the esophagus. You ask if there's any pain elsewhere. As once again, as I emphasized, elderly women have atypical presentations of ischemic heart disease. Yeah. So now we talk about difficulty in breathing. So difficulty in breathing is a very interesting thing. As I've said, I don't use shortness of breath in cardiology. In cardiology, shortness of breath is not applicant because shortness of breath talks about increased work of breathing. If you guys remember respiratory physiology talks about the work of breathing being your passive expiration, your active expiration, and all that, yeah? But difficulty in breathing is impaired alveolar diffusion. Why? Due to edema or swelling. So there's an increased diffusion gradient, yeah? That's difficulty in breathing. So in cardiology, what your presenting complaint is not alikuwa anashindwa kupumua, shortness of breath, avoid it. The old consultants don't like it because they are aware of the physiology. Especially the cardiology consultants themselves, they don't like hearing shortness of breath. So you use difficulty in breathing. And they'll normally tell you it was sudden. The population with compensated heart failure, I know the word compensated sounds huge, a mouthful, but once again, Adnan will take you guys through compensation versus decompensation, I hope, and you'll be able to discuss about it. So it could be sudden, it could be insidious over time in patients who have ischemic heart disease and are living with angina. Most of the time it's progressive. And how do you highlight progression? You talk about how it started, how it was when it started. So the patient will tell you, initially I used to feel this on exertion, but not regular exertion, not difficult exertion per se. They'll tell you, I used to feel it when maybe I was lifting a sack of maize. You know, for a normal person, even if the sack is huge, you should be able to lift it without problems. But then they'll tell you like, I had a struggle lifting it, and but it will disappear when I rest. And then 1 week later, it became present even when I'm seated down. Yeah, and I couldn't do 1, 2, 3 things. And I'll show you how we put it together. And then you talk about how it was on exertion, and then it was relieved by rest initially. So you highlight that. It obviously does not have a radiation of sorts. And then once again, associations put them last. The timing is normally present throughout the day, and you normally interferes with activities of daily living. That is how you measure severity. You ask them, were you able to work? Were you able to brush your teeth? Were you able to do what? And if they say no, those are the activities of daily living. And then the only associations in difficulty in breathing are orthopnea and PND and exertional dyspnea. But most of the time, what they've described to you is exertional dyspnea. And the only associations are orthopnea or paroxysmal nocturnal dyspnea. There are no other associations, please. And that's on Hutchison. So dizziness and syncope. Number one, when a patient told you they lost consciousness, ignore all other presenting complaints. That becomes the only presenting complaint. That should be clear in your heads now. Because just look at how weird it sounds. See, I've said history is about communication, and communication has to be clear and concise. Yeah. So there's no way you will say, patient came in presenting with loss of consciousness for 5 minutes and chest pain. Was he unconscious? Was he conscious? What is going on? So they're already like, this one doesn't know how to express himself, and at waste time. He's wasting our time. So the patient was rushed in, presenting with loss of consciousness. In the cardiology ward, you'll realize that there are key features that will differentiate loss of consciousness. So loss of consciousness or syncope can be divided into 3 types. There's something called neurogenic syncope that my friends in neurology will talk about. There is something called cardiogenic syncope, which I'm going to talk about. And then there's something called neurocardiogenic syncope, which I will touch on because it affects me. So let's talk about activities they were doing before. In neurogenic syncope, most of the time, maybe they had a loud noise, maybe they hadn't slept, they hadn't eaten, maybe they had changed from an anti-seizure regimen, like you know about valproic acid, you know about valproic acid, you know about lamotrigine, yeah? They could have changed from that to another regimen, and now they are seizing, yeah? They could have been had a dose adjustment, you highlight that. For cardiogenic, they could have just been walking and they dropped, or cardiac. For neurocardiogenic, they had to have been doing Valsalva maneuvers like micturating or taking a dunk. Yeah, those are some of the things that they could have been doing for neurocardiogenic, because these are things that trigger the carotid sinus body. They could have been shaving. That's very few people. They could have had a tight shirt on. Yeah, that's neurocardiogenic. So what are the prodromal signs for cardiogenic and neurocardiogenic? So the prodromal, or what is called the preictal signs, you'll find a patient who has a headache. They'll tell you I had a headache, I was dizzy, and dizziness is when they'll tell you, how do you describe dizziness? Patient reports dizziness. He describes seeing the room was spinning. Because if the patient themselves was spinning, that's vertigo. That's a vestibulocochlear disturbance that my friends in neurology are at a better position to talk about. Yeah. And then there's increased awareness of heart rate or palpitations. The patient could tell you that I was sweating a lot, suggestive of diaphoresis. They could tell you that they had chest pain that was central, sudden, crashing in character, radiating to the left arm, associated with no history of trauma, no fever, no cough. Yeah, but there was also increased palpitations. You talk about any change in smell, taste, hearing, or touch. If there's a change in anything, in any one of these, that is probably neurogenic. Yeah. And then while unconscious, what will differentiate the cardiogenic or the cardiac syncope from neurocardiogenic? In the guys who have cardiac syncope, they have death-like pallor, wanaka wafu. They look like dead people. They are pale like dead people. And they are very cold, very, very cold. So how will you bring this out in your history? Don't start saying the patient reports that he was pale while unconscious. You would say bystanders or good Samaritans informed the patient that he was pale, and they described that pallor as death-like pallor. Bystanders who carried the patient to hospital reports that the patient was cold, yeah, had cold peripheries, and they were wet. They seemed wet. That's what clammy means. Ni kama umeshika maji to just initially. Then there is obviously no ictal cry. This one's my friend in neurology will talk about, and they should tell you how they come about. They didn't have any abnormal posturing. These ones you see in focal seizures, and they did not lose any sphincter control. You see in general tonic-clonic seizures. And then the recovery in cardiac syncope is normally very quick, cardiac and neurocardiogenic, very quick. For neurocardiogenic, I know you can easily ask yourself, okay, what is this guy saying? He had me at cardiac syncope, but maybe lost me at neurocardiogenic. So do you know that feeling when you wake up in the morning and the first feeling in the morning is normally to void urine? And when you void your urine, you normally feel a sense of sleep. It's normally like you're feeling sleepy. It feels like you're going to fall if you don't steady yourself. That's neurocardiogenic syncope. And then normally it's quick, then they don't have any neurodegenerative symptoms, like they don't have any amnesia, any memory loss, any alterations in their speech, fine movements, and things like that. Yeah. I hope you guys were together until that point. Any questions so far? I don't think so. Then we can progress. So fatigue is also an important presenting complaint, but fatigue can't be up there. Nobody just comes to hospital because they're tired. Very few people. In Kenya, we have poor health seeking habits. So in fatigue, what they'll tell you is that you will have to really describe about how active they were before. Or is that a question in the chat? Oh, okay. So let me repeat on cardiogenic and neurogenic. I'm not going to touch on neurogenic, I'll touch on neurocardiogenic. So in neurocardiogenic, you guys know about Mark, you know about the carotid sinus body?
Yes.
Where is the carotid sinus body located? Maybe someone can answer, somebody whose anatomy is fresh.
Between the carotid artery.
You're there. I'd just like to add a new term. I'll call it the carotid sheath. You guys remember the carotid sheath? Yeah. So the carotid sheath, closely opposed to it, is this thing we call the carotid sinus body. And so now, in the carotid sinus body, normally is very responsive to the heart rate. It's very in sync with the heart rate. And why is it in sync with the heart rate? It tries to conserve brain function and brain blood supply, shutting down everything else, focusing the key areas of the brain, which to survival is normally just you breathing And that's about it. So it's trying to concentrate blood to the brainstem, because that is physiologically what you need to be technically alive. So now, when your heart starts to beat quickly, what the carotid sinus body is immediately activated, and what happens is you lose consciousness. You start feeling like you're going to sleep, and that happens. So that's the basis of neurocardiogenic syncope. While in cardiac syncope, you're going to pass out not because of trying to a shunt mechanism, but you're going to pass out because in cardiac syncope, your heart is not getting enough blood to your brain. Because that myocardial ischemia has caused muscular arrest, and hence no blood is being pumped to your brain for that moment. So that's how you lose consciousness. So now, how is this relevant? So in cardiac syncope, you're going to have, prior to passing out, you're going to have cardiac manifestations, for lack of a better word. You're going to have that headache. You're going to have that dizziness. You're going to have that increased sweating. You're going to have that increased awareness of heart rate. You're going to have that chest pain. You're going to have these symptoms, but you won't have the neurological symptoms, like something like they'll tell you they had an aura, or that aura normally consists of a change in smell. They'll feel like there's burnt toast, like there's something bitter in their mouth. They won't tell you that, yeah? And then while unconscious, for neurocardiogenic, they are also pale, but they are not as pale. For cardiac syncope, because blood is not getting to your peripheries, they are death-like pale. They look like dead bodies. And then they are very cold. In neurocardiogenic, they might be cold, yeah? But they're not as cold, and they're definitely not clammy. Because clammy means that they have like wet, like their palmar surface of their hands and the soles, they're wet, yeah? And that's important to note. And then when they wake up, both of them, their recovery is relatively quick. I want to give you a key difference. Normally, neurocardiogenic is very common among the elderly. So somebody who's 90 has probably experienced this because they have stiffer vessels, and any change in rhythm is transmitted very quickly and they lose consciousness quickly. But then cardiac syncope doesn't have an age distribution. It's common across all ages. If you find neurocardiogenic syncope in a young woman, normally a young woman per se, you're thinking of a tumor that is maybe around the ethmoidal sinus. Some tumors of the ear, nose, and throat. But those are not our discussion today. But I hope I've answered your question, Mark.
Yes,
Fatigue.
thank you.
You're welcome. So for fatigue, I think we're done with fatigue. Just talk about it, how you can really quantify it. So how are they before the activities they're engaging in before? How are they now? Then for limb swelling versus generalized body swelling, this is normally very tricky because somebody can easily inquire like, yo, is this renal or is this cardiac? The answer is you can never really know. But how you look at them is use the operates model. And I'm not going to go through the operates portion, the opar minus the A. I'll go through the A. So normally, when you have a patient telling you they have swollen limbs, what else do you think can cause a swollen limb? Let me get somebody from you guys. Maybe we can have purity. What can cause a limb to swell, purity? Yes, purity. I'm waiting for you to tell me what can cause a limb to swell. Are you speaking? Because I'm not hearing anything. Trauma can cause a limb to swell, guys. So don't forget my key rule, trauma. No, I can't hear you, Purity. I've just seen in the chat you've asked if we can hear you. We can't hear you. But you can type your answer in the chat. Or It's okay. So you have trauma. Trauma is a key cause. A deep vein thrombosis is the thing that I want you guys to really know about. Because how will you differentiate the edema that occurs in maybe renal failure or the edema that occurs in liver failure from the edema that or the swelling that occurs in DVT? So in deep venous thrombosis, they have a change in temperature. Because veins carry deoxygenated blood, that blood, for all intents and purposes of this discussion, is warm to touch. Yeah. And then normally the swelling is associated with a skin color change because we know as the hemoglobin lets go of the oxygen and takes in carbon dioxide or carbon dioxide, there is a conformational change that occurs to blood composition to the level of color. So the blood that is arterial is normally red. You will recognize it. But the color that is venous is normally, it has a tinge of, you'll see it as, it looks a bit darker and a bit blue. It looks blue almost. If you cut the right veins, you'll see it's very blue. It has a bluish with a red tint. That's the conformational change. So around that area, it's normally darker. Yeah. And then for deep venous thrombosis, it's also painful, tender to touch. And then the next thing that they'll tell you is it's definitely going to be that one limb is more swollen than the other. The other swells, yes, but not as much as one limb. Yeah. And that limb that's swollen is normally the painful one. And then obviously, you have to say if there's trauma, not trauma. And then you ask about liver symptoms like jaundice, pruritus, any abdominal distension. And then you ask about renal symptoms like any facial swelling or swellings elsewhere, changes in urine frequency, color, consistency, smell. Those are the things you have to ask when you have a patient with generalized body swelling. And then now we have your important positives and negatives. I've given you guys the key. And the key is anything in the chest, look for it in the head and in the abdomen. Anything, why do I say the head? Why is the head important in this? Somebody who has an acute coronary syndrome or an MI is an old lady who's maybe she's had a stroke in the past or a transient ischemic attack, which is a stroke that doesn't go on for more than 24 hours. Anybody with chest pain is somebody maybe who could have had a GI manifestation like epigastric pain, could be reflux, could be a typical presentation of ischemic heart disease. Yeah, so that's the rule for important positives and negatives here. And then obviously in the abdomen, the kidneys are there. But if you find a patient with swelling and you've probably asked about the renal symptoms and the liver symptoms, don't repeat. Yeah. Why is the skin important here? How do you normally track your autoimmune, your vasculitides in particular? Yeah, because your vasculitides normally attack small vessels. The vasculitides that I'm talking about are, of course, you have the Kawasaki, you have the Kawasaki that's normally very common in, it's a medium vasculitis, medium vessel vasculitis. And you could have your Takayasu, which is a giant, which is a large vessel vasculitis. We had by the Takayasu case in Kenyatta around February. So don't think that these things are in the books. You find a young woman with hypertension, you're going to have a long day. So you have to know that they normally have skin manifestations like rashes, and they have musculoskeletal manifestations like joint pains and aches. Yeah. And then hypertension is special. In hypertension, you will basically ask about the complications of hypertension. Could somebody tell me about the complications of hypertension? Maybe Baga. I don't know if I've pronounced that name right. My friend Gulam is always on my case about it. Maybe you can tell us. Any complication of hypertension that you know? Are you speaking? Or you're not sure? Because this is a discussion. You can just talk about it as well. But is it possible you can tell me one complication that you are aware of? Just one. I just need one. I can't hear you. I don't know about the rest. Are you guys able to hear her? Could be a problem on my end.
No, we can't hear.
Okay, Abaga, we can't hear you. Maybe you can type it out. Yes, yes, it can cause renal failure. That's a microvascular complication. It's called hypertensive nephropathy. It can cause heart failure. That's a macrovascular complication. It can cause cerebrovascular accidents. Thank you so much, Sadia and Purity. And Baga, thank you so much for responding. So you divide them into macro and micro. So macro, head, cerebrovascular accidents, heart, coronary artery disease, and then the peripheral artery disease. And you guys know how to ask the questions, or you will know by the time you guys are getting deeper into the rotation. And then the microvascular complications are retinopathy. So normally they'll have visual disturbances. And how will you elicit this in your history? This patient will tell you, I used to be able to read my phone. A phone is normally held like roughly just 30 centimeters to the person. And now they have to bring it closer to increase the font. They can't see. And then could be something like nephropathy, renal failure. Could be something like neuropathy. They are having ulcerations at the foot and change in color of the foot, yeah? And then those are some of the things that you expect to see. And that's how you rule them out. So you look for the complications, and that's how you are safe for hypertension in your history. So risk factors, I forgot to add diet here. Sounds an important risk factor. You have a patient who has a history of similar symptoms in the past. You'll have a patient who will tell you they have a family history of similar symptoms. They'll tell you that they use alcohol. I told you guys how alcohol and cigarettes. How do you guys think cocaine is important? Cocaine, methamphetamines, and cat. How do you think they are important in cardiovascular disease? Maybe Angel, you can tell us.
I would say that the amphetamines increase the workload of the heart. And if the workload exceeds the amount of oxygen that's being delivered to the myocytes, that can cause infections. Yeah.
Very nice, very nice, very nice. Cocaine is very special because cocaine causes princemental angina, causes vasospasms. Yeah, and CAT is also a drug that can trigger the autonomic system. And then let's ask about IV drug use, because you guys remember infective endocarditis from pathology. I am not going to belabor. I know Dr. Waweru took you through that. Yeah. And then you have family history of sudden death, although this is not important in the adult population. In kids, it's very important because of something called hypertrophic obstructive cardiomyopathy, which is genetic and runs, I think it's autosomal dominant. Yeah, it's autosomal dominant, if I can remember. If it's not autosomal dominant, it's normally one of those things that are not, no, it's not autosomal dominant, it's non-Mendelian. I know you guys did genetics on Friday, so you could cook me on that, but it's non-Mendelian. So hypertrophic obstructive cardiomyopathy is very non-Mendelian. So it has multiple, it's polygenic, same to hypertension and the rest. And then you ask about dental procedures because you're worried about instrumentation that can cause bacteremia. Then you ask about other chronic diseases that are relevant, yeah? So now you have your medical contact. So as I've told you, where did they go first? What was done there? Did it help? Then they were rushed here. What was done here? How are they right now? That's basically it. And past medical, it just contains these things. I won't add on them because we should know them by now. Have they had blood transfusion? If they have, is it receptive or donor? Have they had surgery? Is it, if it's relevant, by the way, it should be in the HPI. If you have, they've had a surgical procedure like a dental procedure, or if they've had a surgical procedure like a valve replacement, it's very important because it should be in the history, or cardiac surgery of any kind. You ask about any previous admissions, then you ask about food or drug allergies, then you look for TB, you look for hypertension, rheumatic heart disease, epilepsy, asthma, diabetes, the infamous thread. And then family social. Family social history is not for fun. You ask about it with a purpose. And the purpose is you want to say, are the parents, are the siblings alive and well? So we are trying to establish baseline. Could it be that this is genetic? Yeah. And then you ask if the parents are alive and well, because you want to know. Then after that, you can start constructing a pedigree. I know Dr. Elovi told you guys that pedigrees normally head up to the third generations, have 3 generations on them, so you should know that. And then you ask for NHIF. If they don't have it, how are they going to pay? That's very important for some doctors, like some consultants. They really like you to humanize the patient. And then you ask where they live, you ask what they use to cook, and you ask where they get water. Yeah. So then after that, you review systems. And then after you review systems, that one I took you guys through the questions to ask. Then the general exam. I'd want us to do the general exams make sense if you read on it before. So has anyone here read on the cardiovascular general examination, or the general examination in general, and what to look for in cardiovascular history, in cardiovascular setting? Okay, if no one has, general examination will take you guys through this clinically, but what you should know is something called ABC. So appearance, bedding, connections, yeah? And then after you do appearance, bedding, connections, you should have your vitals, so your saturations and your blood pressure. And then after that, you talk about the general exam. So a general exam is just looking. So you look at the palms, because you don't want to go back to the hands again. So are there, you guys know about general lesions, you know about oslar nodes, or as they're called, peripheral stigmata of infective endocarditis. You look for splinter hemorrhages, clubbing and all that. Then you look at their pulse. You should know the steps of taking a blood pressure. So how do you take a blood pressure? In the cardiology ward, the most accurate way to get blood pressure is the mercury sphygmomanometer, but that is no longer used. So there's this one, it's called the manual sphygmomanometer. So how you do it is, you look at the anterocubital fossa, 2 finger breadths above. You have the cuff placed 2 finger breadths above the anterocubital fossa, and then you palpate for the brachial artery. The brachial artery, you should now know how you look for the biceps tendon, you accentuate for the biceps tendon, and then you try and just look for it. You should be able to know anatomically where is the brachial artery. If you don't know, add something you can confer with netters. And then after you palpate for the brachial artery and feel it, what you do is you start inflating the cuff. And you inflate the cuff until you can no longer palpate the brachial artery. And then you inflate 20 to 30 millimeters of mercury higher. And then after that, you inflate 20 to 30 millimeters of mercury higher. You place the diaphragm of your stethoscope over the brachial artery, and then you should note by the point at which the brachial artery became impalpable. That's called your relative systolic blood pressure. And then now you start deflating slowly, roughly 2 to 3 millimeters of mercury per second, while your diaphragm of your stethoscope is over the brachial artery. Start going slower when you approach when you start approaching the relative systolic blood pressure. Around there, you should hear the first corrective sound, which is normally consistent with absolute systolic blood pressure. And then now you continue to deflate until where the sounds disappear. That's your absolute diastolic blood pressure. Then you look at the neck, obviously, for distended neck vessels, visible pulsations, all that. Jack load you guys are aware of. So I think, I don't know what's the time, it's 7:17. Let me share maybe a sample history, and we can go through it. For that, let me just share my screen in a few. Okay, I hope you guys can see the histories. So, right, we're going to just go over a quick case. So I'm going to give you guys just a typical case, and I want one of you to read it. So guys, let's, I don't want to go to my friend Julius here. Julius has a very complicated case that we'll talk about when you guys do heart failure, maybe we'll talk about it. So who is willing to unmute and present, or should I pick someone? Angel, are you at a position to just read this history quickly?
Yes, I can read.
Okay.
The patient is Petronila Atamba, aged 49, and she's female. Petronila has stayed in Kawangware for the past 7 years, and before that she stayed in Limuru for 20 years and Kakamega for 22 years. She is a casual laborer and she was admitted 9 days ago. She's a non-hypertensive and she was diagnosed 2 years ago at a health facility in Kimau on enalapril and is non-adherent due to financial constraints. She presents with a 2-month history of chest pain and 2-month history of cough and difficulty in breathing for 1 day.
2-week history.
Sorry, 2-week history of chest pain, 2-week history of cough, and 1 day history of difficulty in breathing. Then the patient was relatively well until 2 weeks ago when the patient began experiencing central chest pain that was sudden in onset, crashing in character, radiated to the left shoulder, and this was present throughout the day, exacerbated by exertion and relieved by rest. On a scale of 1 to 10, it was 6 in severity, and the patient reports that it was not associated with respiration. There was no prior history of trauma, there was no pain in joints, no changes in swallowing, and no dyspepsia. The patient reports associated increased sweating and fatigue. The patient reports a 2-week history of non-productive cough, sudden in onset, and non-progressive. The patient reports it as episodic and would only appear anytime she took her medication. The patient reports no wheezing, fever, no night sweats or weight loss, and patient reports no other triggers such as dust or colds, which could have set off the cold. Okay. And reaffirms no dyspeptic symptoms. The patient reports 1 day history of difficulty in breathing, which was sudden in onset. She reports initially that she would only experience it when performing a task and it would be relieved by rest, but that at night, the patient reports experiencing it even when lying flat and waking up gasping for air, suggestive of orthopnea and, sorry, I don't know that, postural nocturnal, I don't know.
PND, paroxysmal nocturnal dyspnea.
Okay. Patient reports that the feeling was relieved by leaning forward and hugging her knees. The patient reports a 1 day history of dizziness, which she describes as feeling as though the room was spinning, and a headache that was located at the occiput of her head and was sudden in onset. She describes it as throbbing in character and had no exacerbating or relieving factors. The pain was non-radiating and it was a 6 out of 10 in severity. The patient reports that for the past 3 months, her vision has been progressively deteriorating and can no longer read her phone when it's held 30 centimeters from her without increasing frontal brightness. The patient reports no loss of consciousness, weakness, or double vision, and she reports no hematuria, dysuria, oliguria, or anuria. Patient reports heat intolerance that began 2 years ago initially. Initially, she used to shower with hot water, but now she keeps her showers lukewarm. She reports difficulty inducing and maintaining sleep for the past 2 years and reports that it went from 8 hours to 2 hours per night. There's no history of recreational drug abuse. There's no family history of heart disease, and there's no history of similar symptoms in the past. On admission, the patient was given supplemental oxygen, IV drugs, and had blood drawn for investigations, and a CXR has been done. Do I keep reading? Or
Keep on reading.
okay. The patient's menarche was at 13 years old. Her last normal menstrual period was at 42 years of age. Menopause has been confirmed. She's per 8+0, and she has had seven SVD, and her eighth pregnancy was a cesarean C-section. I don't know if I've read that correctly, but okay. The past medical history, there's a positive history of admission. She had a GI issue in 1989, and the ulcers were managed. A positive history of surgery. There was a C-section in 2013, I think. Preeclampsia. There was hypertension complications in the pregnancy. There is NK, no known food drug allergy, I think.
That's okay. I feel like we can leave it till there.
Okay.
So now, in this history, do you guys remember the 6 things that I said that must be there for your history to be a history? Otherwise, it's just noise making. Do you guys remember those things that I highlighted?
No.
Okay, so maybe I can just stop sharing and switch to that screen. Sorry, guys, I'm eating into your time, but this is important, as by the time we are done today, you should be able to take a history on your own and follow this guide. So your HPI has to have a systematic analysis of symptoms. So that is where your Socrates and your operates come. So for this patient, we had our chest pain and we properly expounded on it. And we really highlighted on the relevant associated symptoms for the chest pain, the cough, and the difficulty in breathing. And if you guys noted, medicine is very important. The patient is on enalapril. You guys did cardiovascular pharmacology with Dr. Monge, if I can remember. And, or was there somebody else who took you guys through ACE inhibitors? Or you guys were under Dr. Monge at that time? So let me just assume you are with Dr. Monge. And I'm pretty sure he belabored on the fact that it's important to know that enalapril or ACE inhibitors, their main side effect is a cough. And it's important to know these things because the patient had a cough. I could have kept on digging for the cough, but she just told me about her medication and I clocked. She was on enalapril. So sometimes that's asking these questions is important. How do they start? Do they have any triggers? That's how you analyze your symptoms. And then you associate with other relevant symptoms. And then you look at important negatives and important positives. So other causes. See, I told you guys the rule. Anything in the chest, look for it in the head, the abdomen. And the true is for any of them. So the vice versa is true for any of them, or the antiversa, for lack of a better word. And then you identify risk factors and etiological factors. For this patient, on the important positive and negatives that we've just read, she's a non-hypertensive, yeah? So what was important to me was the fact that she can no longer read without increasing her phone, and her phone brightness and font, which is very important because I told you guys about hypertensive retinopathy. Where are you guys currently in ophthalmology? Maybe I can ask Angel, where have you guys reached in ophthalmology?
We've only had the first introductory lecture.
Okay, okay, that's okay. So as you continue in ophthalmology, you'll talk about something called hypertensive retinopathy, and you'll talk about the features and the grading, and you will talk about central retinal veil occlusion and central retinal artery occlusion. And you should know that these guys normally have a progressive, you'll know causes of sudden vision loss and progressive vision loss. And one of the causes of progressive vision loss is glaucoma, hypertension, diabetes, yeah? So for this patient to have deteriorating vision, that's a very important complication for me. She didn't have any renal symptoms or something like that. The heat flashes, somebody can ask, why did I inquire about the heat flashes? It was giving thyroid. It was also giving maybe a bit of pheochromocytoma. And those are important things you have to ask. But then only to find out that it was menopause from her obs care and history. And then now you do contact with the healthcare system. I talked to you guys about supplemental oxygen being given and all that. And then current status, symptoms have since subsided, things like that. So I hope you guys can take note of this. Are there any questions about this presentation that we just had? Any questions? Any questions, guys? So I'll take it like we don't have any questions. Are there any questions, guys?
No, there are no questions.
Okay, guys, I hope you guys, this session was really helpful. I'm so sorry I've eaten into your time. But please go out and read. And I know you guys are fresh, but you're not as fresh. This is week maybe 3, 4. And we've taken you guys, I think, through almost every system. And it's important you guys to try and clock. So my name is Sean. My number is there in your groups. Reach out if you want somebody to present to your history. I'm normally around school on some days. So you just call me and you just tell me I'm around Kenyatta 123 at this and this time. You can come with your friends, come with your group discussion. We just talk about that history that you have. And we can be able to see how can we look into it, yeah? So feel free to always reach out, guys. Like, this is not a lecture. We are not lecturers. We have no intention to lecture you guys.